All right, so we're going to get started with our panel discussion on addressing staff retention and turnover in early psychosis care. For obvious reasons, we've had a lot of requests for this particular topic. It is really pervasive in the industry at large, and as we'll discuss, it's particularly challenging in early psychosis care. So really excited to get to address this. So I'm going to go ahead and introduce our panel moderator, Dr. Katie Pierce, who is a postdoc here at UC Davis Health, working with the UC Davis Early Psychosis Clinics and here at the TTA. Dr. Pierce, do you want to take it away?
Yeah, thank you so much for that introduction. And I do want to mention as well, but there are some resources and further readings on this topic in the resources section for the panel discussion. So if you're interested in reading some more papers about this, there's a couple of papers that talk about more rural communities and others that talk about more urban settings as well. So that's available to everyone. So without further ado, let's go ahead and jump in. One thing that I want to note is that during this time, we really want to hear questions from all of you, especially about things that have worked, things that haven't worked in staff retention. So please feel free to jump in, either unmute yourself or pop questions into the chat. And at this point, I would like to ask our panelists to please just give a really brief introduction about who you are and what your background is in.
I am Dr. Richelle Long. I'm a child psychologist. I work in the Sacramento County mental health system and I work for UC Davis. I am a counseling psychologist, so I got my degree from the University of Memphis. I've done a lot of training and work in lots of different communities across the country and all of my different training experiences. And so gotten a lot of experience working in lots of different communities where people don't typically have access to high quality services. And I currently work in a community mental health clinic. I also have some special education and expertise in working with 0 to 5. So I know there have been some questions about families and family life and doing work like this. So I'm happy to help respond to those as well. And I'm looking forward to chatting with you all.
Hi, I'm Kiara Alvarez, and I'm a child and adolescent psychologist as well as a school psychologist, and I work as a research faculty at a school of public health. So my training in terms of psychology has been across a range of settings, but I particularly focused on adolescents and on sort of the continuum from crisis care and inpatient care over to primary care, integration of mental health services, and outpatient care. And prior to becoming a psychologist, I spent about 6 years working both in educational settings with adolescents and families, and also as a forensic interviewer in a children's advocacy center. And so certainly in those contexts, particularly nonprofits, very familiar with some of the challenges, of providing that care, of vicarious trauma, in the course of work and of staff turnover. So I think for me, it's usually a combination of the experiences, later on in my life as a professional, but very much foundational, the experiences of working in under-resourced settings. And most of my work has been with youth of color and their families, and particularly with Latinx and immigrant populations.
So first of all, I want to thank Dr. Alvarez and Dr. Long for being here and sharing their amazing expertise with us. I think it's something that all of us should be paying attention to from both a trauma and a DEIA lens. These are really important pieces that we need to take with us as we work in this space. So most of you probably know who I am. I'm Tara Niendam. I'm a child clinical psychologist. I'm the executive director of the early psychosis programs at UC Davis. And so I have both a Medi-CAL early psychosis program that I've been running since 2011. And then I have a commercial insurance clinic that has been in existence since 2003, but I was really started to take over in 2012. So I'm able to speak to both the commercial and the Medi-CAL sides. Hiring people is difficult either way you go, and thinking about retention on those different sides. I'm also the director of the TTA, and so I've been privileged to be able to speak with many of you or work with many of you in various contexts to hear some of your concerns. And I will do my best to amplify those concerns in this conversation today. So happy to be here.
Wonderful. Thank you so much, everyone, for being here. let's go ahead and go to our first question. So employee openness to new practices is predictive of workplace retention overall. So how do we cultivate openness and change in a change-oriented environment when so many people are really burnt out?
I actually started talking about this a little bit in my presentation earlier, but I think our ability to be open to change and to think about things differently is really dependent on our state of regulation. And if we're not in a state where we're feeling calm and regulated and well cared for and that we belong somewhere, it's hard to get into that space in your mind where you can even think from a problem solving place, or beyond that, to be creative and to be open to new things. And so I think one thing is just creating atmospheres of belonging and really enhancing regulatory practices within the workplace and recognizing the state of stress and doing things intentionally within the workplace to reduce the level of dysregulation among staff so that people are open to trying things differently. Because right now, for a lot of people, and I think for a couple of years, everyone's been surviving. And when you're surviving and someone's like, hey, try this, you're like, no, I just have to keep floating. And so that piece of caring for people, I think, is a big thing that I would recommend.
Yeah, I agree completely. I think that, when so many people are burnt out is the operative phrase in this question, is that you can't, jump ahead from the burnout to be able to make big changes. And you do really need to focus on the climate and the environment in the moment. And I think that, there can also be a question of where the changes are coming from and why they're necessary, and I'm sure many of us have experienced, being in organizations where sort of a big change is, brought in kind of top down, we're going to do this thing, or we're going to use this new practice. And it seems disorienting. And so there's really a question of also, who's involved in making these decisions, and are changes being made in response to the challenges and the issues that employees themselves are raising or that clients are raising, or are they being made, because there's sort of a new practice out there. So I think you really need to think about this question of buy-in, of how changes are discussed, of whether people feel that the practices that they're currently involved in have enough support to be successful, and to really be open to having those discussions and to having these things take time and be done sort of carefully and deliberately. And then I think the other component is also, right, who's leading the change. And so sometimes there can be sort of something new, but there hasn't really been much thought put to who's going to do it and who's going to have the extra workload on this. And so if there are real priorities within a system, having those priorities actually be structured in a context that's sustainable for employees is very important.
I'm sort of wondering, and hearing both of you talk, well, Richelle, because you sort of brought up these things that we can do. Sorry, I'm putting on my manager hat. I'm taking off my panelist hat. I'm gonna own that. Because now I'm curious. I'm like, okay, what do I do? How can I create this space in my own clinic, right? And which then makes me want to open it up to everybody. What are the things that folks have done in their clinics to create space? You guys can put it in the chat. You can raise your hand and unmute. Or what are the things your clinics have done to create that sense of support or community, creative space? What has worked for you all? Because I think, again, I just want to reinforce that part of this learning collaborative is for us to learn from each other and to share things that have worked. If anyone wants to be particularly brave and put in something they tried but didn't work, we'll take that too. That's totally fine. Because I think, I'm sitting here thinking about clients calling in crisis, people referred from the hospital, clients who aren't well, parents who are calling, and I want to give these things to my team so desperately. And then thinking about how to balance that with the need to draw down, services for the month. And so one thing that we've done, I will say, or that we're doing, and we're very excited about it, is we're having a Halloween potluck. And yes, it's going to be in person. We're super excited about that, to come together and like share a meal and share community.
Are costumes required at this potluck?
They are optional, but costumes, there will be costumes on, because we have our team meeting on Monday. So we are encouraging costumes for team meeting on Monday. I'm a very big fan of Halloween. So yes, always costumes. But I think that's something, and recognizing, I think for us in doing that, that it was this sort of balance between people's comfort being in person right now, gas prices and having to drive, all of the space issues in the health system, like how do we do this? And we were all like, we don't know, we're just gonna figure it out. And we're gonna like eat some stuff together around a table. Okay, we got some chats here.
So I want to read this point from Wendy. Says, I met with each staff and asked if they could share what their greatest barriers are in their day-to-day, set up monthly non-clinical meetings to hear what's working and not working as a group, so that I can make sure they feel heard and hear my process for what I can act on or not act on as I bring in new protocols and practices. And also noted that this really seemed to work well for some people, but not so much for others.
Thank you for sharing, Wendy. I want to like really highlight in here a point that you're making as a manager, which is can hear my process for what I act on or not act on. That transparency, that was definitely something that I think as a manager during COVID, we were having to make decisions so quickly. Sometimes we weren't as clear in why. But that level of like bringing people into decision making, Kiara, you sort of touched on that, helping people feel like they're part of the decisions and changes being made. And it sounds like for Wendy that worked well for some folks, but not for everybody. That's a really great suggestion.
I also really like the kind of collaborative focus and the idea that like the thoughts and opinions and experiences of your staff are valued and you care about what they're saying, even if you might not be able to attend to everyone's things or make space for that. The fact that you allowed them to voice what's barriers for them, what's getting in their way, it expresses interest and intent and the fact that you care for them. So in terms of creating that sense of belonging, I would sense your staff would feel like you understand where they're coming from and that you at least want to know how to help and be supportive and adapt, not just put things on them.
And we have another comment that says, we have a celebration committee to make sure we plan fun things monthly for birthdays, baby showers, wedding showers, and holidays. If this keeps morale high and things a little lighter from when we're working through so much heaviness. And I think that actually a lot of this conversation dovetails really nicely with our next question as well. And so this one's talking a little bit more about workplace culture. So shared employee perceptions about work, so feelings about feeling supported in their organization, whether they feel a sense of hopelessness in their place of work can really impact employee turnover. And so part of this question is, if you are someone who's in a leadership role, how do you bridge that gap? Like, how do you learn more about what your employees' experience is like? Or what is that level of disconnect, if there is any?
I mean, I think we can have a tendency sometimes of trying to formalize sort of understanding of things that are already could be just very obvious if you just talk to a few people. And so I think I've definitely been in situations where people have said, oh, we should do a survey to find out what everyone's upset about. But really, you can talk to like 2 or 3 staff and they're going to tell you, what everybody's upset about. Or people have been bringing this issue up in staff meeting, over and over, and it hasn't been addressed. And so I think sometimes, there's kind of a question of, what specifically do we want to understand and what information do we already have about that as a leadership team? What information do we not have and who do we need to talk to understand it? So kind of from the leadership perspective, needing to be really clear in what our questions are, because otherwise I think it can lead to even more burden. Now we're sending out surveys or we're having big meetings. I think another thing that, I've often seen happen is sort of a large group meeting, to say, okay, now everybody share your concerns, and then nobody, shares their concerns because they don't feel that that meeting is a safe place to do it. So I think you really have to figure out what the goals are and how to how to then evaluate, based on those goals. And then also, identifying what conversations have sort of potentially gone underground. What are the things that people are not telling you, but are talking about with each other, which is really impacting morale because there's that kind of recurring, venting and not having any kind of solution. So this question of, what are people not telling you or not talking about, or what do they feel they can't talk about? And I think, when employees bring concerns, really taking that seriously, right? Taking seriously what their perspective is, and what we can do to address it, rather than making assumptions, or sort of the one phrase I wish we could banish is, we've tried to do that before and it hasn't worked, right? Because somebody brings a concern or they bring a solution, you say, oh, we've tried that, it hasn't worked. There's these ways that we really shut down ideas and conversation, and so staying open and being able to gather that information is really critical, I think.
I think there's a piece too of being sensitive to like DEI issues. Who actually gets to bring their concerns forward? Who feels safe and comfortable within the work environment being heard and saying things, and what influences that? And so are there groups within the organization whose voice doesn't get heard for various reasons, and wanting to be attentive to, like, if you send out a survey and a bunch of people are just not going to respond because they don't think so. So you only get like selection bias, only the people who are ready to be vocal. And so really being thoughtful about having meaningful conversations and who's having the conversations with people too. Is it someone who's really connected and has the relationships, or is it someone who feels kind of disconnected, and what impact might that have?
Richelle, I'm wondering if you could speak for a minute about psychological safety, because I think it's something we think about with our clients and our families, and we don't think about with our staff, but is so important in how we create a space for them to share concerns.
Certainly, and I know Dr. Alvarez brought this up in her talk as well, but the idea of like feeling like you are safe to be yourself in your work environment, that you have the freedom to talk about things that are of value to you, that you're able to express yourself fully, and that the things that you bring into the environment will be accepted and appreciated. I love that word belonging. I know Dr. Alvarez brought that up earlier too, and just the sense that who you are as who you are is accepted, and it's okay for you to bring in the positive things and also the challenges, that you're in an environment where you feel safe enough to challenge what's going on, to ask questions. And the way that psychological safety is set up within an organization has a huge impact on like who gets to have that experience, or who gets to step forward and who doesn't, and different issues of diversity. And I know there are specific groups who are underrepresented in different clinics and different fields of practice that don't often have the same freedom or safety to just be themselves, if not challenge the system, which we need a lot of these systems to be challenged, and we need them to be challenged by people who see the systems differently, which are the ones who often aren't given the freedom to speak up and to do that, or don't have the support to be able to do that. And so I think we're missing a lot when we don't intentionally try and set up environments that anyone can belong to, but also challenge.
Dr. Alvarez, do you want to add anything to that?
Yeah, and I would just absolutely agree with that. And I think that, from the perspective of being a manager or even being a peer that's hearing a concern from someone, it's also really working on our own defensiveness and our own reactions in the moment, right? Because things may be said that really impact us. Somebody comes and says, people are being treated terribly here, and you've maybe worked really hard on making it, a good environment. That can evoke a lot of emotions, but it's very important to one, be aware, recognize your own emotions, understand that the person is coming to you for a reason, right? They chose you to talk about this issue with for some reason. They think you're somebody they can trust, or they think you're somebody that can make a change in it. Whatever the reason might be, they made a deliberate decision to speak to you. And so the defensiveness can really can really derail that conversation, or it can really send messages about like, oh, okay, I'm not going to come back to this person about this again, so that I think is a really important piece, being able to recognize our own reactions and address that appropriately at a later point with another person, but really in the moment being open to what the experience is. And I think also being aware of what our steps are in terms of listening, at the same, like you're saying, the same way you might think about with clients. You want to listen, actively reflect and understand the problem before you jump into problem solving mode, which may feel dismissive. On the other hand, you also don't want to stay forever in the listening mode and never fixing anything because people came to you to fix something. So kind of trying to find that balance and letting people understanding it's an ongoing conversation, that you can let someone know you're taking something in, you're going to follow up with them about next steps. I think often where people start to feel very discouraged by their workplace culture is by feeling like we've been raising these issues, what the issues are, and nothing ever changes, nothing happens, right? So really trying to move out of that process. And I see there's some comments coming in about like transparency and about some of those different things, which I think are going to be very relevant to that.
Yeah, one part that I wanna highlight that you just said though is that as the manager, we are hearing this regularly, right? And we are humans, people. We are humans too, and it can be really hard to feel like you are trying to make change and it's not working. Like that's just frustrating for any human. And so then I think what we have tried to do is to make sure that our supervisors, our leaders also have spaces to process that, right? So they can continue to hold that safe space for the staff member or the trainee or whomever, the client, right? But that they also have a place where they can come in and be like, I keep trying to fix this and it's not getting fixed. What am I missing? Because I feel like for myself, if I'm trying to hold that, it is not an infinite pit that you can put challenges into. It does fill up. And then I have to manage it too. And so I just want to make sure that as we're talking about this, we're sort of focusing on our staff, but we also need to retain our managers and our supervisors. And this can sometimes be the thing that takes them down, is sometimes feeling like they don't have a space to go to or a leadership that's responsive to them. And we have to think about that level as well. Yeah. Thank you for highlighting that. Yeah.
Absolutely. And I want to take a moment too to give some highlights from the chat as well. So one person's mentioning that they have a committee that has provided other staff with things like water coolers. They got every employee the Calm app, and they're working on other things to try to support. Another person commented that we're working on fostering and embodying hope for possibility and hope for change, for connection, by modeling our value of people being people. Also highlighted is the importance of transparency around administrative functioning, normalizing a lot of pain or the grief that can come with working in this type of environment with a lot of different types of stressors. And also important to know why the staff are coming, to you to talk, whether someone's coming to you to need a space to vent, a space to move forward, someone to talk to if they're feeling stuck. And also another comment to saying that there's an importance to having mutual space that allows for staff and leadership to share the structural difficulties inherent in making changes. So I'm seeing that really as a theme when you want to make changes, but there are structural or inherent problems that are getting in the way. So let's move ahead to our next question. This is really wonderful discussion. I feel like we could stay on any of these for the entire hour. So for the next one, if it takes clinics time to increase employee salaries to keep up with the cost of living, what can we do to retain people in the meantime? So some examples of this could be things like offering flexible hours, remote work, different training opportunities, upward mobility, partnerships with childcare agencies, things like that. Are there different ideas on how to retain staff, and how feasible are some of these ideas?
Makes me kind of curious about like if any of you have tried any of these things on the list, and if they have been helpful? It seems like a good list to start with. And I'm wondering if that's like the status quo and we're still losing a lot of people, or if these are kind of things that haven't been tried yet.
Going to jump in with a comment from the chat.
Yeah.
So as a friend recently shared that her job just amounts 2 weeks a year worth of paid time off to work out. The time needs to be dispersed and not taken at one time. So like one day off. They work for the Department of Defense, and they're wondering about different funding for things like this.
Well, that was what I read that made me want to. I was reading the other day was to the 4-day work week. So you get work 4 days and you get paid your full salary, and like some of the data that's coming out of that pilot program in the UK, you know, and how in some ways it's working. I think that COVID is allowing us to think in other ways about how we do work. And so I appreciate Robert's comment here, you know, offer remote work options, allow staff to avoid commute hours. That's definitely something that I try to do. I think one of the challenges we're seeing in our clinic is that our clients are starting to want to come back in. And so the idea of offering remote jobs is now sort of shifting. And additionally, for some folks in some spaces, like that's just not a great way to build a relationship. Like it just doesn't sort of jive with who they are as people. And so while it might work just fine for me, it doesn't work in other ways in terms of building connection and community. And so I think we're sort of challenged right now about this whole work from home option. I certainly feel that way in the hiring space. I think one idea that is not any of these things is, yes, Robert, I would love to work 4 days as well and get paid for the rest. I think one thing that I have really talked to a number of programs about, and this is going to seem super counterintuitive, but is really being very structured in your expectations of time. So one thing that I've implemented in my clinic is a template, a scheduled template. And so it is very clear about exactly how many client slots you have, how many hours you are supposed to have that are billable, and then how many are not, and putting in things like a lunch and a break and making sure that those don't disappear. Ensuring that they actually have the time in their work week, their legal work week of 40 hours, 42.5 when you add on 30-minute lunches, that is what they're expected to work. Not more, not less. And if their work is overflowing from that, then we've got an issue. I think I've seen that some workplaces are like, you get to pick your schedule and be super flexible. And what I've seen often happens is that then just people just pile in a bunch of stuff, or their work schedule actually doesn't reflect what they're doing, and then they end up burned out. And so I think one of the policies we really tried to implement in our program is like, these are the hours you work, they are templated, you are expected to do these things and not anything else. And if it goes outside these boundaries, let's have a conversation, because it shouldn't, and we have to make an adjustment. And I get a lot of pushback at the beginning, but then once people really see that that's the expectation, they feel more comfortable setting boundaries and saying, I'm ending at 5 today. I can't do this today. I can do it tomorrow, or I can do it next week. But you start to expect that time is finite and that all of us have boundaries. And so it's something that we've really tried to do and encourage other folks to do. So that has nothing to do with pay. It just has to do with being honest about hours. So I'm seeing lots of things in the chat.
So I'll go ahead and read some of those for the recording. So one is a larger idea is for our county to have the clinic hours extended into the early evening and adding Saturday. Then clinical staff can work Monday to Thursday or Wednesday to Saturday, 10-hour days. So having some flexibility there. Another person is saying we've explored options in our workforce development funding to offer some small loan repayment programs, 10K, outside of state and federal programs in exchange for their years of service with the county, and work in certain populations, such as early psychosis.
I would add, I think that, what we really know about burnout is that burnout is very high when you have high levels of responsibility and low autonomy. And so I think having that as sort of an underlying principle, the idea that in some cases we are sort of taking away people's autonomy somewhat falsely, right? Like we're saying, if there are opportunities to provide people with a bit of autonomy, like, you need to have a doctor's appointment during the week, as a team we will make that possible, by providing coverage or whatever the case may be, is really different from being in a situation where people tell you, well, you have to be at your desk, from this time to this time, and you have to respond to emails within, this amount of time. I mean, there are workplaces where the conditions externally may seem the same, but the way things are enforced or talked about, is very different, where people are discouraged, for example, from taking their vacation time. So I really liked what you were saying about, really, really keeping an eye on what the person's schedule is actually supposed to be and making sure that employees get to use that time, because there's a real difference between, for example, being able to take a full week's, vacation. And of course, you have to worry about things like clinic coverage and planning those things in advance, but a difference between that or working someplace where you feel like, oh, well, it's never okay to take vacation here. My manager doesn't take vacation, or people only leave for 2 days at a time, or whatever the case may be. You can have really workplace norms that are either focused on fostering very sort of low autonomy in the workplace and being very dictated, by kind of managerial practices, or you can really create situations where within your constraints, at least, people have some freedom, to choose what works best for them.
I just want to say, like, us making sure we're doing what we say we're doing. I think the hardest thing for me was that schedule that I was talking about, me implementing that with my staff, and then my staff telling me, but you don't do this. And they could see my schedule, so they knew what I was doing. And I had to be like, you're right. And they were like, why should we believe what you say? Why should we believe that's okay? I was like, fine, I will fix it. I still am terrible at it. So but I own that, like, how hard it is. It is so hard to make those changes and to protect that and to say no. But I have to walk the walk. I can't just talk the talk. And that's difficult, but I think, it really does speak to the system that we're working in. Yeah.
I think too, you both have talked about like these unwritten rules or kind of like clinic culture things. And as managers, I think thinking about what are the unspoken rules and actually clearly defining them, because maybe you're a super high achieving manager and you always respond to every email within like 10 minutes. And that's not realistic for other people, right? So like, what is the culture that's being set? Like, and say it clearly, like, we expect people to respond to emails within a day. That's realistic, right? And so what is the actual expectation versus what are people doing? And then as staff, as clinicians, being able to actually ask questions and know it's okay to ask questions about things that are like these unspoken rules, because a lot of times they kind of build this culture, but nobody ever actually decided on them. It's just kind of how people have learned to practice the job throughout time. So bringing it up can actually be really helpful for starting some of these conversations and noticing like, wow, I'm feeling really stressed out because I feel everybody responds to emails immediately all day. And that's not possible for everyone.
And I really appreciate those ideas of, we often set standards for, you have to have, your notes done within this amount of time, and that makes perfect sense. But like Dr. Niendam is saying, we don't always set such hard expectations for, and you need to be taking your breaks, and you need to be taking time for yourself. And I think the emphasis ends up getting put more on one than on the other. So I really like that you're all bringing this issue up. And I do have a couple of other thoughts about this conversation from the chat as well. One person's mentioning the one thought could be, because often in healthcare, 30 or 32 hours is considered full time, but that's prorated for benefits. And so, but noting that it might not actually carry over to PTO. So maybe an opportunity to have additional PTO, perhaps instead of salary raise. Another individual saying, my staff burns out around paperwork. So trying to really pare down the documentation to just what's necessary. And just to make sure that that fits into the schedule.
I'm just wondering, so we have CAL-AIM coming up, right? Which is supposed to be documentation reform. Please let it actually be documentation reform. I'm wondering if there's also ways in which we could support, could we do some harmonization or some, I almost said the T word, the TEMPLATE, which we're not allowed to use, but some, some harmonization around documentation to help people not feel like we're all recreating the wheel. Is that an area where the TTA could be helpful? Or like I'm looking at Adriana Furuzawa here, who runs, I don't even know how many counties you put in your, like, I'm signing in. Adriana, you and Bruce are so funny. Adriana, you have programs across counties, right? And I'm just wondering if together, some of us who've been doing this, especially for some of our smaller counties or our newer counties, we could sort of work together on those things to just help folks see how we've tried to streamline a bit. What do you think?
I couldn't agree more. And I will just try to create some boundaries for myself, because no one needs to hear me ranting about how we need to advocate for equity or parity for our behavioral health documentation and our general health documentation. Like how much easier it is for a physician to, or anyone in the medical field, to document the services they provide and demonstrate that the service was provided within the time claimed, and how complicated it is for our behavioral health providers, particularly in community mental health, to demonstrate the same. So I think that I'm a firm believer that every opportunity is an opportunity to be taken, unless it's not truly an opportunity. But with CalAIM, we do have an opportunity to at least advocate with clarity for what we need. And I would go with the full template, but the harmonization, if it is a more acceptable word. And after all, a lot of it, we shouldn't have to translate the work that we do just so it meets certain requirements. We should be able to describe what we did in a way that meets the requirements. Mm-hmm. So I think more collaboration, perhaps with county QM, county QA, so we have clarity on what the expectation is, and if the quickest we could translate that collaboration to the person immediately providing the services, I think we would start to move the needle in staff retention. That's really what I'm hearing from the staff, is that folks chose to be in this field, let alone early psychosis, to do the work, and their barriers to doing the work is really what's making them think twice before doing this work.
Thank you, Adriana. I so appreciate your partnership, and I really love your point of like the equity between behavioral health and physical health. Like we have to justify ourselves 16 ways to Sunday, and like that is not what has to happen in other places. And so how can we keep pushing towards that? I really appreciate that.
I did want to make a comment related to this from the equity perspective in our workforce, and I think it's just to note that, in healthcare, because it mentions upward mobility, right? And so in healthcare, our most diverse part of the workforce in terms of race and ethnicity, as well as our probably least paid part of the workforce, are the ones that have the least upward mobility, right? So we're putting people in these front, facing client roles that have high levels of responsibility, that really use all of their skills in terms of the services they provide, but also the expertise, and lived experience that they bring to the table. And then there's very little mobility up versus people in other managerial roles that have more options and sort of a career pathway, essentially, right? So we don't have career ladders for a lot of these roles. And that is a really important piece. If people can't see where they're going, and I think, as was just mentioned, people are in this work for a reason. So it's also not necessarily that they want to see themselves going into something that takes them away from working directly with clients, but they want to be able to be in those roles and still have ways to grow, still have ways to show that they're growing, on paper, and that they're being given new responsibilities. So that's one important piece of it. And I would say the other important piece is that what you often see in systems for these staff is also that people do take on new responsibilities. So they're more senior in the group. And so now they start training the new hires, or they have language skills. So they're also expected to translate or interpret instead of having a budget, for those services. It comes down to the staff, or they're very good with community outreach. And so they get sent out for those things. So you see this job creep, where now your job actually involves a lot of other things because you're quite good at it. But that's not reflected either in their salary or their title or how they're seen within the agency. So those are things I think also that really need to be paid attention to is, what are the jobs people are actually doing? How has that changed over time? And is their compensation, and their sort of job description really keeping up with that? Because otherwise you do end up burdening the people that are probably the most committed or have the skills to bring to the setting and kind of pushing them out before they can really devote those skills.
I love this comment, Dr. Alvarez, and it actually, I think, dovetails so well with our next question about, we often talk about how important it is to have a really diverse workforce, so people with different cultural, racial, religious backgrounds. But when we have a lot of people from a lot of different backgrounds, what do we need to create in our places of work to actually be able to better support them?
So actually think of this answer while you're talking, Dr. Alvarez, and it's more of an answer to this question anyway. But the idea of representation. And so if you have like the primary workforce being more diverse and you have like, as you climb up the ladder, it becoming less diverse and most likely more white and looking in a very specific way, you also have this experience. Like we have also a lot of like earlier career people in that like first tier of direct line clinicians and high rates of burnout. You have this paperwork burden, you have all of these layers of things. And I don't know how often managers and supervisors, like up the ladder, how often people are talking about their own experience of burnout or what it was like for them when they were in those roles. And so you have this experience of like, you look up the ladder and there's all these people who seem like they're doing fine. And is it because they look like that? Or is it because, like, what is it? Is it the job? Well, I can't get to that job from here, so I might as well leave. Or is it like something about the differences? And so that idea of representation and making more pathways for more diverse employees to climb the ladder and to have expansive leadership roles within the organization, but also just creating space for modeling and talking about these things that are so common and so human that I think having some of those conversations could be really helpful in kind of normalizing just the human experience of doing this work and everybody's experience of doing this work. I don't know that happens very often.
Yeah, and I would add that, we have this kind of with that idea about sort of as you work your way, through the system, right? We have this survivor bias also of, I made it this far by doing these things. And some of these things were adapting to really adverse circumstances and in ways that we shouldn't have had to. But that was how we made it, or how we were taught to adapt. And I think, being aware of that and being aware of what are some of the messages that we have potentially internalized that are pretty toxic about what it means to be committed to your work, or like you were pointing out, earlier about how many hours you put into the work. I mean, I know certainly when I started out in nonprofits, that kind of constant, we're here for the mission and not the money sort of message. And it was like, well, yeah, we know that. I mean, obviously, like we took this job, but that's also not a reason to exploit your workers or to say you don't need to worry about the conditions that people are working under. But there was a lot of messaging around things that were okay and not okay to say. And certainly for me, like as a Latina, the messages I got when I was coming into the workforce about what was okay to do or not do were luckily somewhat different, than the messages I think some of my younger, staff now have. And I try to learn from them, right, about how some of these things were actually, quite toxic and that need to be revisited and done differently. But I think also this question about affinity groups, about creating spaces where people can be themselves, where people can have support, for their backgrounds that are salient to them. I mean, I know, when you're sharing a particular role, particularly if you're hiring people in order to be responsive to a particular community, you really need ideally more than one person. Again, speaking only to my own experience, I've been in the situation of being the only Spanish speaking person, in an organization that's serving Spanish speaking people. And I've had the experience of being one of, 4 or 5. There's a huge, huge difference between having people to share that work and that experience with, or being expected to sort of be the only one in an organization, which I know for many people, the experience of being the only one of their racial background or the only one of their religious background, that's quite a different challenge. And so we do have to sort of make it very intentional, and also very intentional to understand what are the biases and structures that exist in these systems before we bring people in. Because we put a lot of, I think, onus on people to integrate themselves into a workplace rather than on what the workplace has done to make it a welcoming place for everyone.
I think some of the pieces that we, and this sort of goes back to the last question of like retaining people, because I think it is also acknowledging the point that we have folks coming in, they're coming in as case managers, as peers, as maybe as clinical trainees, yay, how do we keep them going? And I think for some of us, it's really recognizing that is the beginning of their career, and how do we support them to the next stage and do that with intention? And so when I have my new staff start, I'm like, what's your career goal and how are we going to support you in getting there? And so that might mean that my peer is with me for 2 years, but when my peer goes off to nursing school to become a provider in the community that she is from, that's huge, right? And so I think it's also for us creating that, being intentional and creating that ladder for people, and making it so that it's okay to leave. And boy, we hope you come back, so that they return to us later with more skills, and then we can promote them further. I also want to pick up on one of the pieces that Kiara, I think you said, is that people, this job creep, like being very clear that like you're giving leadership opportunities to people on your team so that they are leading something and not just doing something. Like if you have a peer that's really great at outreach, great. Why don't you lead our outreach team, and that can become part of your work? And what do you need to be successful in that, right? And maybe that is support resources, who knows? But that then should become part of their job description, should be discussed in their annual review, should be the reason for a raise, so that you can retain them, but you're also supporting them in that next career step, which is, I think for me, having representation, it can't just be about us. It has to be about everywhere. And so we could be a vehicle for that change. And even though the person might not stay in our clinic, they might go on to another clinic. That's still great. And we have, more diversity in our clinics and in our community. So I think, that's a really important piece. I also want to just touch really quickly on the issue of like, we do this for the mission and not the money. I can't tell you how many times I've heard that from people recently, especially with the increase in wages. And I just am like, that mantra is such a privileged statement to be able to be here. I'm just here for the mission. It's paying my rent, I don't need a new car. It is such a privileged statement to say that. And you are that is why we see certain people in leadership and not other people, because they don't have the choice to choose the mission over the pay. And so I really do think we have to, and I bring this up all the time in meetings as we talk about salary and equity, that, we expect to have a diverse workforce. We have predominantly women in our workforce, and there's an undervaluing of the work that we do. And that is why people are leaving. It's a high stress job that we don't get paid for. And so I really want to encourage all of us to fight back against that notion, because that right there will cause you folks who can't choose mission over money. They can't do it. So you will limit your recruitment on that alone.
There was a comment in the chat. So in response to this conversation, one person's sharing that they like to make sure they include their team and their clients' backgrounds as part of the clinical picture and story when they're talking about them, when they talk about systemic issues individually and as a team as well. And also to make sure to publicly own your own blind spots and mistakes so you can try to model that for the team, to make it easier for them to share their perspectives as well, and create their comfortability around sharing some of those perspectives.
I just finished reading Adam Grant's book, Think Again, and he's a organizational psychologist. He works in the business world, but he talks about with his students, they made this video that they now show to every new class of all of the professors reading off all of the bad reviews that are like evaluations that they've gotten from their students. And that's how they start every like academic year, is playing this video of all of the people. And they did it at Microsoft as well. And Melinda Gates did the same thing and read off a list of all of the things and really shifted people's perspective of her as the leader of the organization. And what they found is that people were a lot more likely to say when they made mistakes and actually be more creative and take risks and try things and enjoy the work that they did, because they had a little bit more autonomy in how they did things and felt like they were free to do that. Kind of back to the psychological safety. Psychological safety also involves the ability to make mistakes and know that it's not going to be the end of your career and that it's okay. And everybody knows that this is what happens. And guess what mistakes I've made when I was in your shoes. And I think that goes a long way. So I like that suggestion a lot.
So one of the themes that I've heard come up a couple of times is the difficulties that rural communities face. So I've heard from different people who've been sharing in the chat and speaking about how it's difficult to find staff members. And then there's also so many barriers for clients, for consumers of services, trying to get to these spaces. There are a couple of those papers to read, but one of them was really talking about how one of the best predictors of whether clinicians really stay in these small communities is how well integrated they become into them. And so, is there any way, if you recruit people to a more rural setting, you can help support that integration to improve retention?
I think you do have to start with understanding where employees are coming from, what their past experiences have been and how they're seeing the community that they're integrating into, because it could be that there's points of commonality for them, that they feel very comfortable with. It could be that they feel very different and distant from the community. So I think a starting point of really understanding, each person's sort of position and needs, as well as what are, potentially the commonalities that might help integrate them if there's a particular, sort of thing that they like to do, a particular activity or hobby or something that they feel comfortable with, that they might be able to find some community around. And then I think it's also important to understand how the community views people that come from outside the community, because in some rural areas, and areas in general, right, rural and urban, there can be very different views to people coming in from outside the community, especially in healthcare roles. And so understanding what that sort of receiving environment is like as well, and what can make the health system, the clinic, more integrated into that environment. I think it's very different if you have a very trusted sort of group of providers that have been there a long time and have some connections that can help bridge new employees into the community, versus if the entire clinic is seen a little bit as a sort of an outside group. So all of those kind of individual and systemic factors, I think, might be relevant.
And I have a question from the chat as well, just some curiosity about why there's such a strong link between, whether a person becomes integrated into the community, whether they stay. Being curious about whether it's related to their knowledge of the culture, to local resources, or social connections. Some of what I saw in the paper that I drew this question from was that a lot of people who came from outside the community, the paper talked about how a lot of them made friends with each other. So you had a lot of people coming in who were new, who formed a group together, but the people who really integrated with the community, that really found a sense of belonging there, were much more likely to stay.
Inviting people to go out and to do things within the larger culture, because what I'm sort of hearing you say is if folks are left to their own devices, they're going to gravitate towards other new people and create a little bit of an out-group as opposed to the in-group of the current local folks. And in doing that, and they might other themselves from, am I kind of understanding that correctly? I wonder if it's that some people are super good when they come to a new place about wanting to get to know people and immerse themselves in the space. That might be harder for other people. And so as the program, you want to make sure you're integrating people and not just asking them to do it on their own, because it might not work out so well.
I'm wondering too, I don't have a whole lot of experience working in rural settings, but I did my internship in New Orleans, clearly not rural at all, and very easy to find fun things to do there. But one thing I really appreciated, just from talking from an organizational standpoint, is every Friday, pretty much, all of our faculty, the people who work there, our supervisors, would just like tell us about the fun things going on, or like the cool things to do, or things that were going on that weekend. They're just kind of a normal conversational part of Friday afternoons, was like, oh, have you heard of this is going on this weekend? Or you've heard of this is going. So we always had something to go do that was a part of kind of the culture and community of where we lived. And we knew it about it because our supervisors always made it a point to let us know what was going on. And that was really helpful.
Yeah, I'll say I love the idea in the chat about having supervisors or leads take staff around. That happened to me in a community that was, very, very, I don't know, I wouldn't say it was closed to outsiders, but it was just had a very strong, like closely knit community where everybody knew each other and had worked together for a long time. There were lots of relationships, and someone took the time to just walk around with me and walk into places and introduce me. And it was really, I think, a really welcoming experience. And then also gave me some context for when I saw people again to say, oh, hi, I met you with so-and-so. So I do think that like kind of touch of really making those personal connections in places where that's very important is a good idea.
Are there any like closing thoughts that people have that are generated from this panel discussion? Like, are there things that are actionable that you think that you can do to implement in the short term that might improve staff retention? Or have there been things that you've done that worked as well? I see Giselle, you have your hand up. Go ahead.
Hi, yeah, I'm not management at all or anything. Listening to this is really, really enlightening for somebody who's maybe not privy to a lot of the managerial conversations, but I really do appreciate a lot of this. One of the biggest questions that I have is that this really has helped me identify a huge gap between our clinic and really just maybe upper management, or maybe, and I would really just like to know from your opinion how I could best raise this and try to get some more support, because at what I have been doing so far, maybe what my coworkers have been doing has not been working as effectively, and it's creating a lot of barriers to starting this very important program. So I would just love it if anybody could address how somebody from maybe a lower ranking position as far as organizationally can speak up about this, and how.
I think going back to that idea of psychological safety, finding someone who maybe is above you, who you do feel safe with, and starting to ask the questions, like using the pathways that are available to you, if that's an option. Not everybody has that option or has that sense of psychological safety. And so thinking about ways, being intentional about how you're framing the question, the issues, because then again, from you don't want your managers then to get frustrated, or it's just another complaint, or you want people to actually be open to what you're wanting to say. And the reality is your team probably has a lot of really good ideas and understanding. It's just creating that openness. So I would explore the pathways that you already have, but also think about like how to wonder about things with people and how to kind of create open conversations that don't have as much of an intention, that can communicate the things that you're asking about, that you're struggling with, but from a curious place where you can also try and understand why these barriers are in place, and if there are other things that again are just kind of unspoken things that the management hasn't been very open about, or if you're able to ask questions, that might be an easier way to get in if you don't have those natural pathways.
This is such a great question. I think, one thing I tried to do before I was where I am now, I was just like like assistant professor, like who wanted to help people. And so how do I do, how do I do this better? Is I would look at the people who were doing it better. And so for me, in my work, there's another organization at UC Davis, the Care Center, and they've been around for like a couple of decades. They're just really good at what they do. And so I would go to them and I would like, how did you do this? Could you share this with me? Who did you talk to? And they would sometimes point me to other people that, as Richelle sort of suggesting, might have those connections or that knowledge that you need. So is there another group within your organization that does get the time, the attention, the resources? And is there anyone in that group that you could go to and you could say, you guys are great. You guys are doing awesome. Like, look at all of this. This is fantastic. Help me understand how you made this happen. I would really love to grow our early psychosis program. Please tell me how you were you're being so successful. Everybody loves when you like praise them a lot and then, and ask for their like mentorship. They're, oh yes, please. But it's like looking for those people who figured out the game and asking them how they play it.
Thank you. Thank you guys for answering. I really do appreciate it. It's really good insight. Just due to kind of some unforeseen circumstances, unfortunately, we don't have a lot of direct pathways, but I do like the idea of looking at other teams who have maybe started kind of from the bottom like we are and so to speak have gotten up and running. So I think I really like that idea and I definitely appreciate your guys' insight. Thank you.
Thank you so much to our panelists for their insights. And thank you so much for everyone's comments and questions. These are wonderful. I posted the article that I mentioned a little bit earlier for rural communities in case anyone wants to take a peek. But otherwise, thank you. And I'm going to pass it back off to Jessica for our closing.
Here's our citations and references for those of you who would like to see that. Those are in the slides as well. And then finally, thank you all for attending. We really appreciate your dedication to providing early psychosis care and hope this has been a useful learning experience.